There aren't enough palliative care people, so us oncologists are going to have to step to the plate. There are a couple of easy things to do. One is partner with a palliative care team if you can find a good one. Not everybody is suited for this. Number two is every time the CAT scan changes, you know the prognosis has changed. The patient's not going to know unless you let them know. So your job is to gently ask, would you like to discuss what this means? That gives control of the information to the patient and the family, and they can say, no, I really don't, just tell me about the next chemotherapy. Or they can say, yeah, what does this mean? Because you know the next round of chemotherapy has less chance of working for less time, and it's maybe time to start planning for a transition towards end-of-life care. Third is really plan that transition. Make sure that you get hospice involved early, so that it can be a planned transition. I tell my patients, look, I'm getting worried about where the cancer is going. Let's discuss prognosis if you want. But one of the things I like to do is have you meet with hospice while you're still relatively well. That way they can get to know you, you can get to know them, you know what services they'll provide, and if it comes time that you need hospice care, we'll have it already set up. It really works for me. I don't know a single oncologist who's tried it, who's gone back to the old way of, you're too sick for chemotherapy, now it's time to switch to hospice, and that person only has 3 days or 5 days left to live. That's actually considered by FASCO as a marker for poor quality care. One other simple and easy trick that the oncologist can do is a clue from palliative care. In Jennifer Temmel's lung cancer trial, which established that this was the standard for lung cancer, there were almost no notes in the oncology chart about how are you coping. Whereas on the palliative care notes, there was 15 minutes devoted to how are you coping? And then physically turning to look at the family and say, you know, mom's pretty sick. How are you coping with mom being sick? And then just listening to the answer. The answers can be hard sometimes, which is sometimes why we don't ask them. But that's another reason, if you have a good palliative care team, to get them involved, because those are the things we'll do, and it may help take it off your plate. The other fascinating part is based on our research, which shows that, frankly, patients and families may find it easier to discuss some of these difficult things with somebody that they've never met before than with their treating oncologist. People protect us as the oncologists. We ask, why would you rather discuss this with the admitting team rather than the oncologist? And the answers were, I want them to keep treating me. I don't have any plan for what happens if I stop treatment. I want to protect my oncologist. It'd be too hard on him or her. And number three, it'd be too hard on me, because we've bonded as a treatment team. So it's really good to bring up these issues early, have a reflex that whenever the situation changes, the performance status changes, a serious complication, the CAT scan changes and shows progressive disease, that's the time to ask, how do you like to get medical information? Are you the sort of person who wants to know all the details? That's what we agreed on last time. And then, what is your understanding of the situation? Oh, okay. And then gently guide them to what your understanding of the situation is, which is often much different. Then I have a couple follow-up questions. I say, well, what's important to you? What do you want to accomplish in the time that you have? And what are you hoping for? Those two open-ended questions will get you right to the heart of who the person is, what they want to do with the time they have left, and how they want to spend that time.